I'm Matt Wade, Dr. Wade, and Dr. Kedhar will join us in a few minutes. He's actually, believe it or not, in surgery right now. So he's doing what we're talking about, and we'll give him a pass for that. He's helping someone see better. Okay, so today we're going to talk about what cataracts are and what the latest technology is in cataract surgery. And if you're anything like me, you know, when you get into things like this, there's a lot of questions that come up. I would love for this to be fairly interactive. In fact, I have a kind of few questions as teasers to each part of this. So please share things in the chat. We'll try to jump in. I'll ask Dana and Lewis and Will to kind of prompt me with what questions come into the chat so we can address those. Please be aware though, we're doing this, we're going to record this, it's going to go on YouTube, so I can't, you know, you don't put your own personal medical history in that if you can help it, and we'll go from there. Okay, so first off, I want you to feel like you're in school again. I want to feel a little pressure here. What is a cataract? Is it a film on the surface of the eye? Is it the natural lens inside the eye that has become cloudy? Or is it a common type of reversible vision loss? Let's see what people think. Okay, now while you're thinking about that, I'm going to say it's very common for people to not know exactly what a cataract is. The second two answers are actually correct. It's a common type of reversible vision loss, and it is the natural lens inside the eye that you were born with, that was clear and flexible when you were born, that has become cloudy. It is actually not a film on the surface of the eye. That's a common misconception. Okay, question number 2. What are common cataract symptoms? Halos and glare, need for more light when reading, glasses prescriptions not working well, meaning you go to your optometrist and just they can't get you a prescription that works well, or pain. We're actually going to be grading these, and whoever gets if your score is too low, you're going to get kicked off the Zoom call. So try hard. Just kidding. So actually, the first 3 here. Cataracts cause halos and glare, the need for more light when reading. They cause your glasses to not work too well, but they generally do not cause pain. If you're having pain or other sensations in the eye, it's typically something else, not just the cataract. Okay, so this is a schema of an eye, and you can see this leaf here on the outside of the eye, and you have the light rays go through the cornea, which is the front window of the eye. They go through the lens, and then they end up upside down on the retina. The retina, if you think of the eye like a room, is like wallpaper inside of that room. It coats the inside of the eye, and it takes that image and then translates that to the brain via the optic nerve. So in this instance, you can see that the image of the leaf is clear on one side, clear on the other side. That's a healthy functioning lens. Now you may see this patient, and you can see on the left side, there's a black pupil, meaning it's clear. Light is getting through there easily. And on the right, you can see that it's cloudy or white. So on the right is when that lens has become a cataract. And so what that looks like here is that image of the leaf coming through into the eye. The light gets scattered by that lens. And then the image on the retina looks all cloudy. And you can see these little light scattering rays are kind of going everywhere. They're not just going exactly where they did before. And so this highlights how blurred vision occurs from this cataract or cloudy lens. Other symptoms include, we talk about blurred vision. Oftentimes there's difficulty with night vision. So at night, you know, we have this great pupil. The pupil expands or contracts depending upon how much light there is in the system or outside or wherever you are. So if you're out at night and it's dark, your pupil is going to expand to let in as much light as possible. Now, if you have a cloudy lens, that pupil opening up is going to uncover more of that cloudiness. And then when you see bright headlights, you're going to have a lot of glare, halos, or other things around those. So that's why you have more difficulty at night. We talked about light sensitivity in the question. Light coming in hits that cataract, bounces everywhere in the eye, and causes light sensitivity. You can even have double vision or blurred, offset in the vision that you're, or the image that you're seeing. fading of color, the lens itself becomes really cloudy. And as it does so, it acts in some ways like a pair of sunglasses. It blocks out certain colors. And so one of the things that people remark about the most on the first day after cataract surgery is how bright the colors are. They can see now that the cataract is gone. And of course, if you have lenses inside the eye that are blocking the light and keeping light out, it's going to require you to have more light when you're doing activities such as reading. So people often say, well, how do you treat this? Can we just treat this with drops? And unfortunately, there are no current drops that will help dissolve or treat a cataract. That would be a great thing to have, but that's not a reality at this point. People ask next, well, can I treat it with diet? Can I just change my diet and this is going to go away? Again, unfortunately, that's just not the case. Certainly, a poor diet can lead, for instance, if you have a poor diet and diabetes, that can lead to a worsening of the cataracts earlier in life. But changing your diet at this point is not going to change the progression of the lens. We can often fix this with a new pair of glasses. And you may ask, well, why is that going to help? Well, as the cataract progresses and the density of the lens itself changes, the refractive index changes. And so your prescription changes. And you'll notice that as your cataract progresses faster and faster, your need to change glasses to keep up with it increases until finally they're just not doing it for you. The definitive answer for cataract treatment is cataract surgery, which is that last image here of a microscope. Okay, next question here. So when is it time to consider cataract surgery? A, when you're having trouble reading small print despite glasses. B, when you have trouble driving due to glare and difficulty reading signs. C, when you have trouble writing checks or filling out forms. Or D, when your friends have theirs done. This is obviously not too hard of a question. You don't want to base it on when your friends do it. All the other answers are correct. They're all realistic or real reasons to consider having cataract surgery. So let's talk a little bit more about that. Oh, first another question. What can you do before seeing the doctor for the first time to have your cataract evaluation? A, stay out of contact lenses for at least 2 weeks. B, treat your dry eye symptoms. C, spend time thinking about your preferences for vision with or without glasses. And I'll admit, this is a little bit of a trick question because I didn't put a wrong answer on this. All three of these things are useful things to do before you see the doctor for your cataract evaluation. Okay, so say that is coming up. You have an appointment coming up to get your cataract evaluated. What exactly are we going to think about beforehand? Well, contact lenses fit on the surface of the eye, and many people who wear them for many hours a day and have done so for many, many years. The contact can be very safe, but when it's on the surface of the eye, it actually changes the shape of the surface slightly. So in order to get a good set of measurements, we really ask you be out of contact lenses for a minimum of a few weeks prior to getting your measurements. So taking those contacts out, being in your glasses, allowing the cornea to kind of relax into its natural shape, that is a great way to prepare and to make the most of your visit when you get there. The second thing is treating the dryness. Now, tonight, you're going to hear us both talk about dryness a lot. And it's going to maybe even be a little shocking how much we talk about dryness when you came to hear about cataract surgery. But dryness and dry eye is really critical to treat in order to get the best results from cataract surgery, in order to get the best measurements prior to surgery, and in order to have the most comfort and best vision after surgery. So in that we're talking about what can you do before you get there, let's first take some preservative-free artificial tears 4 or 5 times a day. That will help treat any concurrent dry eye. So we can first of all determine how much of this blurry vision is coming from dryness versus the cataracts. It's not uncommon at all that people will come to see me having been told they have cataracts, thinking they have cataracts, and they do, but they're more mild. And when we treat the dryness, they say, hey, I'm good. I can hold off on any surgery for now. So treating the dryness is definitely key. Okay. Any questions so far? Dana, Lewis, anything coming up?
Nope, I think your polls have been getting responses, but so far, no questions.
Okay, sounds good. So say you prepared for your visit, you're coming in. What happens during a visit to evaluate if you have cataracts, and what are we doing during this visit, and why does it take so long? What's going on? So let's jump into that. Well, the first thing we're going to do is sit you. I'm not personally going to do it, but one of our staff will put you in front of a phoropter, this quintessential, eye technology that's been around for a long time, and ask the question that my wife always makes fun of me about. Is it better one or two, right? Do you like this one or that one? And what our staff is trying to figure out is, what is your current best corrected vision? If we change the prescription and update it, what are we going to get to? And Sanjay's here, so come on in. Sure. I will adjust this so we can both be seen. This is Dr. Kedhar. So we've talked about kind of the intro. We've gone through a few questions. Sure. And we're talking about what's going on during that initial visit. And I just started talking about, do you want me to keep going for a little bit? And you kind of jump in, okay? Perfect. Good. Your experience just got upgraded immensely here with him here. So with the phoropter, we're trying to see what your best corrected vision would be now, to see if cataract surgery is even warranted at this point in time. Is your vision too good that you don't perhaps qualify for it? So we check this. And then, like I said, we're going to check the surface of your eye. We're going to see if it's a normal, smooth surface, or if it's bumpy and lumpy, like we often see with dry spots in a patient who has a dry surface. So this is a picture of the surface of an eye with a little green stain added on. And you can see all these little spots. Imagine how the light is just going to have a hard time getting into that eye clearly when all these dry spots are there. So again, this is what a cataract can look like. It's this cloudy lens inside the eye, not a film on the surface, but a cloudy lens inside the eye. And we'll also look in the back of the eye. The retina will be looking for things like macular degeneration. This picture on the right has some early macular degeneration. And then we'll start getting some scans. Do you want to talk us through some of those?
Sure, yeah. And again, just to emphasize that, all of these things that we're doing here, one, we're trying to figure out whether cataract surgery is going to help you, whether there are alternatives that you might consider, things other than surgery that might be better for you. And also if you have other problems with your eye that may need to be addressed before cataract surgery. So for instance, let's take these pictures here. So these are two photos of something called an OCT scan. What this does is it uses light and then creates an image of the retina. You can imagine that the previous picture that Dr. Wade was showing you, that orange circle with the optic nerve of the retina, that's sort of as if you're looking kind of right down on a birthday cake, for instance, and then these are slices. So if you take a slice of that cake and you turn on its side, you see the layers. That's kind of what we're looking at here. And on the left side, you see that this is a normal retina. These are all the layers. You see this little divot in the middle, which is called the fovea. That's the center of your vision, and that's normal. On the right-hand side, you see that there's fluid. There's lots of these black sort of cysts or spaces there that indicate that there's fluid. And you can get this from a number of reasons, including diabetes, sometimes macular degeneration, if there's inflammation in the eye, certain drugs, certain kinds of chemotherapy can also cause it. And that can cause blurred vision in and of itself. So sometimes you might think that it's a cataract that's causing the problem when in fact it's a problem with the retina and it needs to be addressed in a different way. So part of all of our scans or part of all of our workups here before cataract surgery is to look at the retina and make sure that it's healthy. The other part of this is we want to make sure that your retina has the capability to appreciate an improvement if cataract surgery is done. So sometimes patients have scars or damage to the retina, and even if you take the cataract out, it's not going to change the vision there. So again, this is all part of a complete exam, trying to make sure that cataract surgery is right for you and that it's going to help you. And even if it's only going to help you, maybe not 100%, but 50% or 40%, at least we can give you a sense that yes, your vision is going to improve, but it's not going to be 20/20, or it might not be perfect. This also gives us a chance to, we'll talk about this later, but to evaluate which types of lenses might be beneficial for you and which lenses should we not use when we do cataract surgery. So here we have on the left side, this is a normal cornea. On the right has a cornea with astigmatism. So astigmatism just means that the curvature of the cornea is shaped differently in one direction than another. And what happens is this causes the rays of light that come into the eye to misfocus. So some of them will focus in one area, some focus in another area, and you don't get a good sharp image. And astigmatism can affect both the distance vision and the close vision. So it is something that, you know, if you want to have the best vision possible, the astigmatism needs to be corrected. And we'll discuss it later, but there are a number of ways to correct that both surgically and non-surgically. So here is a machine called a keratometer. This machine creates a three-dimensional or a topographic map, I should say, of the cornea. So you can imagine everyone, some of you may be familiar with topographic maps from hiking. It gives us a sense for mountains versus valleys. And here what we're looking at, the red or orange areas are kind of the mountains. The green and blue areas are the valleys. And this is what would be what's called a regular astigmatism. So this is a normal kind of bow tie pattern around the center. And many patients will have this, and this can affect the vision, both distance and close, as I mentioned before.
Yeah, let me just jump in.
Yeah,
So
please.
I like what you said about this being regular. There are different types of astigmatism, and some of them we can treat quite well during cataract surgery. Other types, as you know, the opposite of regular is irregular. And if the cornea is irregular, that means some of our options are limited in terms of what we can offer you treatment-wise after surgery.
And this instrument is called the IOL Master. So this is pretty standard across most practices these days. And this machine measures both the curvature of the front of the eye, so it checks for astigmatism, but it also measures the distance from the front of the eye to the back of the eye. And this gives us a sense for the power of the lens. So the lenses are a little bit like shoes. They come in, you know, whole and half sizes, and we put those lenses in based on these measurements of your eye.
Sorry.
And no, that's okay. And so this will give us that information. So this is a very important part. And I think as Dr. Wade might have mentioned earlier, making sure that the surface of your eye is as lubricated as possible and that dry eye is taken care of will give us the best measurements here as well.
Absolutely. And getting all these tests is part of why this first visit or even a repeat visit takes quite a lot of time, because we need to get these, it's important. We're basing our surgical treatments on these. And so plan for some time with your visit.
And sometimes we do the testing and maybe the testing's not as accurate as we would like it to be, and we have to repeat the testing. So we might send you home and say, let's try to work on the dry eye a little bit. We'll come back in 2 to 4 weeks and recheck and see how it looks, or maybe longer, just to get the most accurate measurements as possible. Because as you can imagine, if we don't have good measurements, we're not going to have a good outcome after surgery.
So we take all those measurements and we put those measurements into equations. And these are some of the different equations that we have to predict. For instance, say we're taking Sanjay's measurements. These equations will predict what's the perfect lens for Dr. Kedhar, and vice versa for any of us. And there's some variability that we can talk about here, but basically we're getting that data so that we can know what to put in your eye. That's how important that is.
I think one of the other important things here on this graph is, and it's, looks like a subway map to me, but if you look at this, one thing you should notice is in the left axis, the y-axis here, you can see that there's something called prediction error. So no matter, the important thing here is you see none of these formulas that we have go straight across the middle down that say 0, meaning that it estimates or predicts the lens exactly in all patients to get exactly the measurement or the prescription that we want after surgery. There's an error no matter how good the measurements are and how good the formula is. It can be off, but it's not off by a lot. It seems to be generally for most formulas, it tends to be just a little bit, but depending on patient factors, so axial length on the bottom is what we talk about with the distance from the front of the eye to the back of the eye. So that's an important measure for these lenses. As it goes to the extremes, either shorter or longer, we have more variability in terms of how well the equation can predict. So this is another reason why it's important to have a good conversation with your surgeon, with your doctor about what your expectations are afterwards and what we realistically can do with surgery.
Yeah, that's an excellent way of putting that. Okay, so I'm going to walk you through a few of the steps of cataract surgery. These are images only, no videos. You can look up videos if you're brave enough on YouTube, but really the surgery is quite well tolerated. There's very little, if any, pain. First, an incision is made into the peripheral cornea, the clear part of the clear window in the front of the eye. And then the cataract itself has a capsule or a support system. So a small opening is made, a circular opening into that support system that allows us access to the cataract itself. That cataract is broken up, typically using an ultrasound probe, and all those pieces come out. People sometimes ask, can I take my cataract home? And the answer is no, because the cataract has come out in hundreds and thousands of tiny little pieces that have just been sucked out by this small probe. And then at that point, a new lens, we had a lens, that was the clear lens that we were born with. So we have to replace it with another lens. That lens is folded, inserted in through that small incision, and then placed into that support structure. And that's what improves your vision. And at that point, you'll have a clear patch that's put on your eye and you're sent home to recuperate. So I thought we could kind of use this slide as a jumping off place to talk about what does recovery look like after cataract surgery? Do you want to start us off?
Sure. So, most patients don't have a significant amount of pain after cataract surgery, but it's also not, it is normal to feel like there's a hair in the eye, foreign body sensation. Sometimes the eye is irritated a little bit that first day. Usually by the next day, patients feel, closer to normal. Occasionally, if the pressure is high, they may have some pain or discomfort, in which case definitely we want you to call us so that we can bring you in, check the pressure, make sure everything is okay. The first night after cataract surgery, when we have this clear shield on, the vision is blurry. People oftentimes have a lot of halos around lights, and that's normal. As you heal, the vision is better, typically by the next day, but oftentimes the vision, to get the final visual acuity and to have everything settle, it may take up to 4 weeks for that to happen. And there can oftentimes be some ups and downs during that 1 month after cataract surgery. Sometimes people say, my vision was great the first day after surgery, and then it sort of got a little bit blurrier afterwards, and then it recovers later. And part of that is just the use of the drops, and dryness tends to be a little worse after cataract surgery. So that can affect the vision as well. In terms of activities and restrictions, I'll let you.
Yeah, sure. So the main things we ask is, the reason that clear shield is there is so you don't rub the eye. Most of the time during the day, that's not a problem, but at night when you fall asleep, you can forget. So we ask that you wear this clear shield at night to keep yourself from rubbing the eye. And that's really for the first week. Now, really, we don't ever really want you to rub your eyes. So keep that in mind. But for the first week, that's pretty critical. The other things we ask, you use the drops, you treat the dryness like Dr. Kedhar talked about. And we say in the handouts, no heavy lifting or straining. Any pressure or too much pressure that's in the abdomen can be transmitted to the eye. And we want those incisions to heal and to close properly. So take good care. Tell patients not to go swimming or get in a hot tub for the first week or two after surgery. But by and large, you can walk around, you can ride your bike, depending on where we aimed the eye and how quickly your recovery is happening, you can drive.
Mm-hmm. We also, I think one of the common questions that I'm asked, I'm sure you are too, is like, when can I get back to tennis? When can I get back to golf or pickleball now, right? So I usually tell patients, let's try to wait a couple of weeks. You don't have to be inactive, as Dr. Wade just said. You can walk, you can bike, you can move around. But in terms of like strenuous exercise, we would rather you waited a couple of weeks just to let everything heal, to make sure that everything goes well.
Awesome. Any questions at this point?
Chat.
Let's hit chat.
There are lots in the chat. Do you want to share them with each other?
Sure. Do you want to go to the top?
Sure. Okay, let's talk about, let's just start from the bottom here.
Okay.
How long until you can swim?
So I tell patients at least 2 weeks, preferably, if you're going to swim underwater, ideally 3 to 4 weeks, but at least 2 weeks.
Okay. So I'll take this one. How can cataract surgery be done if there's prior PRK? So PRK is like LASIK. And definitely when you come in and talk to your surgeon, they need to know if you've had PRK or LASIK in the past. That's an important part of this because it does affect certain things about this, which lenses we can use and our accuracy in terms of getting you that outcome that you need. So yes, the answer is yes, though. You can have, and everyone who has PRK eventually will get cataracts because we all get cataracts. So yes, you can have cataract surgery if there's a prior PRK.
Another question that came up is once it's confirmed the patient will benefit from cataract surgery, how long does it take for surgery to be scheduled? That's variable. It depends on the surgeon and time of year. Sometimes there's more patients at certain times of years, maybe less around Christmas time or New Year's. So it really depends on that. But I would say it can vary anywhere between like 1 month to 3 months, I think is typical. Would you say?
Yeah, I would say.
Okay.
So let's see. The next one is, what type of eye drops do you recommend for dry eye? That's a great question. It's really not the scope of this, but I want to give you a little teaser for some of the other presentations. We love preservative-free artificial tears. You can really use those as often as you like. Those are available without prescription at any drugstore or supermarket. So look for those. The reason we like the preservative-free versions better than the preserved has to do with the impact of the preservative on your cornea over time. If you're just using it a few times a day, preservatives are fine. If you're using it more than that, you want to search out something that's preservative-free.
Can cataract surgery be repeated? So typically cataract surgery doesn't need to be repeated. Once the natural lens is removed, the cataractus lens, and an artificial lens is placed, the cataract doesn't typically grow back, so it doesn't need to be repeated. There are occasions, and it's not common, but there are times when we will go back and remove the lens that was implanted and place another one. And so that can be, sometimes patients are unhappy with with some of the multifocal lenses. The halos that they get are worse than they expected. And so we can go back and remove that and place a more conventional lens in that place. Rarely, I'd say this happens far less frequently than it did when I started doing surgery 20 years ago. But if we are off in our measurements or in our estimation and the lens is not where the patient wants to be, for instance, if the patient wanted to have good distance vision, but for some reason wound up more nearsighted than we expected, one of the options is to go back and exchange the lens, or we could go back sometimes and do PRK or LASIK over that to kind of correct the vision. So we don't typically do it. It's not common, but it can be done.
Excellent. Okay, can surgery be done on someone who has wet macular degeneration? So when you have any type of surgery, you can have swelling afterwards. If you have knee surgery, you can expect the knee to be swollen afterwards. And we do get some swelling in the eye. Typically, that swelling, if it does occur, is in the macula. So someone who already has wet macular degeneration already has swelling in that area. So that patient, we'd love for their macular degeneration to be treated as much as possible. And if they're going to go in for cataract surgery, which they can definitely have, we typically ask that their retina specialist give them an injection or a treatment that's going to keep the swelling to be minimal as possible.
So another patient asked if I'm terrified of having eye surgery. Can you get monovision with cataract surgery, one for distance, for example? Yeah, so monovision is something that can be done, and it's not, it is done, with reasonable frequency. Typically, when I'm seeing patients for monovision, I really want to be sure that they are going to be able to adapt to monovision. Having one eye distance and one eye close does throw off your depth perception. And so we really want to make sure that people can function that way. So many of the patients that we do this are already functioning this way because of a prior LASIK where they had one eye distance, one eye close, or they wear monovision contact lenses. So in those patients, I feel much more comfortable saying, yes, we can go ahead with monovision. If a patient really wants monovision and they've not tried it before, sometimes what we can do is to try contact lenses for a week or two just to see how those patients are doing. And that's something we can fit in the office. Yeah.
This is great. Thank you for all these questions. So Here's one. Is it okay to go for a massage 4 days after surgery if I turn my head rather than facing straight down on the massage table? I personally, again, back to the principle of keeping pressure off the eye and not rubbing the eye for the first at least week, I would not be comfortable with you doing that in the first 4 days.
All right.
One or two more.
So I think one said one lens distance, one close up, will glasses be required or eliminated? So typically, if you have one eye for distance, one eye for close, your brain oftentimes will switch back and forth between the two. So the idea behind doing monovision like that is to eliminate glasses, or to, I think I'm just going to make one aside here, which is I think there's a lot of claims out there and patients have this perception of like eliminating glasses. And I think a better way to think about it is reducing your dependence on glasses, because for any of these lenses or anything that we do, there's probably going to be one situation where you might need glasses to really get the best vision. Maybe it's reading a menu by candlelight in a dimly lit restaurant, or it might be, something else like, golfing or camping or something like that. So I think eliminating glasses, I'd rather not use that term, but reducing dependence, that's the idea behind monovision, so that you don't need glasses for most things, but you might need them for some.
Yeah, and I think that's just an excellent point. Regardless of the setup, regardless of what we're doing, that's always something to think about. Okay, let's see. Does the new lens, so some of these questions are starting to get into what we're about to do next. So we're going to talk about some of the different options here, and we'll jump into that. Thank you. Keep posting your questions, and we'll try to get to as many of them as we can. Okay, so a little thought-provoking question here. Distance aim, meaning we're trying to get you to see as well as possible without glasses at distance, is preferred in all patients, only in patients with dry eye disease, only in patients who are currently seeing well at distance without glasses, or it's a personal preference. You want to walk us through that one?
Sure. So, the aim after cataract surgery really is a personal preference. Some patients will, and I'd say maybe the majority of patients really want to see well at distance without glasses, and they're maybe more amenable to wearing reading glasses. But we have patients all the time that spend most of their time up close, intermediate. For instance, some people that live in nursing homes, or some people that are, maybe even people that are jewelers, for instance, or fine artists. They spend most of their time, most of their days looking up close, and they prefer not to wear glasses for that. And so we'll make them nearsighted, meaning give them their focal distance up close, and then they'll wear glasses for distance in those patients sometimes.
We didn't really do a lot of intro, but I have 4 kids, and I would never buy them the same birthday present, right? I mean, I have to get something separate for my daughter versus my sons. And the art of this whole thing is meeting with your surgeon and discussing what your goals are, what your preferences are, and having your surgeon discuss with you what like Dr. Kedhar said before, what's possible for you and what they recommend. So we can try to get into this, and we'll cover a lot of this right now, but just keep in mind the real way to do this is in a one-on-one conversation with your surgeon. Okay, astigmatism treatment is A, not important. B, is required to see well without glasses. C, can be done via a toric lens. Or D, can be done via a laser cataract surgery. We have one answer here for C. And B. Want to take that one again?
Sure. Yeah. So I'd say that it's B, C, and D. I mean, you definitely, if you astigmatism treatment, as we'd mentioned before, astigmatism will affect both your distance and your close vision. And so if you want to see well without glasses, then that needs to be treated surgically. It can be treated either via a toric lens, which is a lens to correct the astigmatism that's placed in the eye, or and a toric lens is not necessarily different from the other lenses that we're going to discuss, many of the lenses that we can have the astigmatism kind of correcting component to them as well. So for instance, a lens that's multifocal looking at distance, middle, and close can also correct the astigmatism at the same time. In some patients, correcting the vision via laser cataract surgery is preferable, especially if it's lower amounts of astigmatism. And those are things that we can discuss or can be discussed with you with your doctor, cataract surgeon.
Yeah, I just want to highlight that again, if we want to see well without glasses, it really is key to correct the astigmatism. And so there's a question up on the side, what causes astigmatism? Astigmatism is something you're born with. Definitely there are certain diseases that can cause a progression of that, but for the most part, we're born with it. It changes slowly over our lifetime, and it's just something that we treat either with glasses or contacts, or like we've mentioned with these surgical options. Okay, so it's a little bit of math. Don't get worried too much. This is a typical glasses prescription. If you go into your optometrist and they write down what your prescription is, it's going to have this first letter, which we've called A, which is basically the correction for distance or near. If you're nearsighted, it might be minus. If you're farsighted, it will be plus. But regardless, that's the part that has to do with far or near. And then the second two letters have to do with the astigmatism. This describes how much astigmatism you have, and any pair of glasses you get, it will always have the correction for both distance or near, as well as the astigmatism. So again, the astigmatism in a normal cornea that has no astigmatism, it's the same steepness in all directions, whereas one that has astigmatism has steepness in one axis and is flatter in the other axis. You want to talk a little bit about this?
Yeah, so we mentioned this briefly, but this is the lens, the toric lens, corrects astigmatism there, and with the laser can correct the astigmatism as well. And the way the laser corrects it is that it makes these very fine incisions in the cornea, and it kind of relaxes it so that it can relax back into a more normal position, as opposed to being curved differently one direction than another.
And just with anything in the body, we aim to treat the astigmatism to get to zero, but the body responds how it's going to respond, and sometimes you're going to be left with a small amount. Mm-hmm. In some rare cases, just like with those lens formulas, you're going to be left with a little bit more, and we may need to make an adjustment. So these are all things that are part of the experience. Okay, so I kind of lied. That's not the extent of the glasses prescription. If you're mid-40s and above, like I'm reaching into, not only will you have a distance near prescription and a astigmatism part of this prescription, but you're going to have something that's going to help you get range, right? For instance, I can see with my glasses at distance, but I'm having a harder time reading up close. And so my eye doctor will put a little bit of prescription on the bottom of those glasses, either as a progressive or a bifocal or trifocal, to give me more range. So understanding what glasses do to give us a correction and help us see better kind of helps us understand what we're getting into with the lenses we would put inside the eye during cataract surgery. I'm going to talk a little bit about how.
Yeah, so I mean, if you look here, this is sort of, I mean, on the left side here, when you're looking at your glasses, this is sort of simulating what a trifocal lens would be. You have the top area for distance, the middle for intermediate vision, and the bottom for near. And on the right is a bifocal, so you've eliminated that intermediate vision. It's mostly just the near and the distance there. Oftentimes, patients that are either less demanding about their vision or perhaps a little bit younger can get by with just the bifocals. Sometimes people that have more hobbies or interests that are in that computer distance and really need the fine vision for that. I have some accountants that are like that, where they need to be able to look at detailed spreadsheets on a computer. Then they need that intermediate vision as well to be as sharp as possible. But these are glasses, right? And we'll go over kind of how this is a little bit the way that the lenses that we put inside your eye for cataract surgery, they correct your vision in a little bit of a different way. So you're not looking at different places within that lens inside your eye the same way you are with glasses.
Correct. Mm-hmm. And one of the things that this kind of helps me think of is, if you didn't have, if you're over 45 and you didn't have these additions, these intermediate or near additions on the bottom of your glasses, you can see well at distance. That's going to be there. But when you go to read or look at your phone, you're not going to have the clarity you want at that. And the same is with cataract surgery. If we aim for distance and we get you seeing well there, you'll see very well. You'll be happy there. But when you look at your phone, you won't see that clearly. Just like without this correction here, you wouldn't see it with your glasses. Okay, so sorry, I did 3 instead of 4. But when I break this down for cataract patients, I say, okay, look, there's distance, there's intermediate and near. Maybe you want to just walk them through what those different things.
Sure. So distance probably is what we would perceive as, looking at road signs when you're on the highway or on the street. Maybe looking at your TV across the room, a picture across the room hanging on the wall. Intermediate is more of the, I would say, computer distance, like if you're sitting at a desktop sort of thing. And then near vision will be reading, or when people are holding things much closer. That's typically what we consider the near distance there.
And there, these are 3 groupings, right? There's a lot of things in between. I have people who are engineers or musicians or artists who say, I need to be able to see exactly right here. I mean, the more specific you can be, the more we can help you. But these are the main 3 groupings of distances that we think about when we're thinking about surgery. And there are an infinite number of possibilities of lens choices and aims and things we can do. And so to simplify this quite a bit, I'm going to just talk about 3 of these, knowing though that these are not the only 3 options, but there are 3 that kind of help illustrate the points. So the first is a standard lens, again, not correcting for astigmatism. Remember, we talked about how astigmatism blurs everything. So if we're putting a standard lens in, whether we aim for distance, intermediate, or near, if we don't correct the astigmatism, we're going to be in glasses all the time. We may get lucky and the astigmatism may end up low enough to where we can see at one of these zones without glasses. But really, if we're using the standard lens and we're not correcting astigmatism, we're planning on glasses for all different distances. And then you want to talk about distance with astigmatism correction.
Sure. So if we can correct your distance vision fully, including correcting any astigmatism there, with what they call a monofocal lens, that then will allow you to see well without glasses for distance. So let's say you're driving, looking at the highway signs, or you're out walking, you may look at the mountains or a house nearby. But then when you want to look at the computer, or when you want to read something, you'll need glasses to basically change the focus of your eye to be able to look at those things.
Awesome. Why don't you take that one?
Sure. And then, a third option would be, well, let's correct everything, right? So these would be what we call multifocal lenses. And these give you a chance to be, as we said, not eliminating glasses completely, but for most things, really reducing your dependence on glasses. So you would be able to drive, for instance, then come home, sit down at the computer, type up your emails, and then before bed, taking a look at your book, reading in bed before that. All of those things you could generally do without needing glasses.
And is there free lunch here? Do you get all that without any side effects? Or
so absolutely not. One thing is, sometimes as we get more range of vision, we sometimes will give up a little bit in terms of the quality of the vision. So people might then perceive halos or more glare. Sometimes people can have reduced sensitivity or contrast sensitivity. So in certain lighting conditions, that the dimly lit restaurant that I mentioned before, perhaps the vision's not quite as good. You're not able to read quite as well in dim lighting as you can in bright lighting.
Let's see, I was going to say something. Oh, yeah. And in most people, that small decrease in the quality of vision is acceptable. But if there are many other things going on, for instance, the macular degeneration we talked about, the dryness that's severe, irregular astigmatism, those can cause a further worsening of the vision to the point where it's more problematic. So again, that's why we check for all those things during the testing period. Okay, so this highlights just a little more nuances. Say we talked about the correcting for distance vision, correcting that astigmatism, seeing well at distance without glasses, needing them for intermediate and near. In between that and this trifocal or seeing everything, there are lenses that are trying to make the best of both worlds to give you more range, not all the range. You still need some glasses for fine reading, but they can give you more range than you otherwise would have, with less of the glare and halos that you would have with full multifocal correction.
Mhm. Yeah, and so I'll put one aside here, which is that, again, when I started doing this, I felt a little bit like Henry Ford. It's like you can have any color car you want as long as it's black. It's sort of the same thing. Like at that time, you could have any lens you wanted as long as it was a monofocal lens. But now we have a lot of other options. It's dizzying, even for physicians, to go through every single one and to look at that, because these lenses are being developed every year. New ones are coming out. We're seeing which patients these will be best for. But as Dr. Wade said, the best thing you can do in terms of trying to make a decision is to think about what your needs are. So where do you spend most of your time looking? What kinds of things? Oh, perfect. This is a good segue here, right? So, do you want, are you someone that doesn't mind wearing glasses for any distance? You don't mind wearing glasses all the time? Or are you someone says, hey, look, when I'm out golfing, I don't want to wear glasses, but I really don't mind if I'm at home and I'm reading, that's okay. Or there are other people that said, hey, I had LASIK done 20 years ago so I could have all my vision corrected, and I really want to get back to that. So maybe then a multifocal lens is best for me. And as Dr. Wade said, also knowing, you don't necessarily have to get it down to the millimeter, but if you knew kind of approximately for reading mid-range or reading close up, how far from your face those things were, even if you could just demonstrate it to the physician, that's going to help us to really get you what you want out of cataract surgery. Or, again, if cataract surgery is not really needed, glasses or a contact lens, or being able to address those kinds of things with you. So it's very important that you do a little bit of homework, a little bit of thinking before you come in as to where you're having problems with. What would you like to see, your life be like in terms of glasses and vision afterwards? And then we can then narrow down all of these choices for you and discuss them in more detail.
Yeah, and I would just add that be honest with yourself. I think some people come in, say, I don't mind wearing glasses, and then afterwards, when they can't see as many, things without their glasses on, have a little bit of regret about that. So, and you can have regret on the other end too. So just try to be honest with yourself. And sometimes it helps to involve your spouse. I've had many patients who they say, oh, I don't mind this, or I want this. And their spouse raises the hand and says, oh, actually, what he or she really complains about all the time is this. So involve people who know you and try to answer some of these questions here. So here's a few other questions that kind of help the physician hone in on what lens to recommend to you. And I, initially, when, I would go through this with people, I would put down every lens basically, and we talk about every single one, but there's just so many lenses now, and the nuances are so subtle that I really feel like having an outcomes-based approach to what you want is the best way to have that conversation. What is it that you're trying to see with or without glasses? And then, yes, you can get into the nuances of the different lenses, but start there, and that will keep things a lot more, keep it from being too confusing, I think.
Mm-hmm. Yeah.
So this says, please check the statement that best describes you in terms of night vision. Is it very important to you? Some people say, I don't, I really need to be comfortable driving at night. It's part of my life and my job. Other people, it's not so important. And we have, I think, 2 or 3 more questions like this. You want to take that one?
Sure. So, I mean, this one says, if you could have, so what this is asking basically is, if we can give you less dependence on glasses, are you willing to trade off seeing, say, sort of halos, rings, or starbursts around lights at night for this better range of vision? So again, this is kind of what we talked about before. There's no free lunch. Every lens that we have at this point has some compromises to it, whether that compromise is decreased range of vision or alterations in the quality of the vision that you're having. These are all things that we want to discuss with you.
Exactly. Okay, if you have a cataract and would like to reduce or eliminate the need for glasses, and this is true, insurance will not cover part of the procedure. For instance, the laser or the toric lens or these upgraded lenses. This question is just asking, would you be willing to pay for that? And I tell patients all the time, look, there may be options that would be wonderful for you, but if it's going to mean that you don't have money to feed your family, or you can't do what other things that you want to do, then maybe that's not the best option for you. Whereas if it just means you're going to have, one less jacket in the closet, then this would be a good investment for you. So things to take into account. This is one of my favorite ones. Do you want to take this one?
Sure. So, again, I think getting back to Dr. Wade is like, be honest with yourself, be honest with us, and see, whether your personality is someone that's easygoing or are you perfectionist, because, as we talked about these, we're replacing your natural lens with something that's man-made, right? That man-made, nothing man-made is ever going to be as good as the natural lens is, but I think we can improve things a great deal. We can improve their vision a great deal. But if you're someone that's a perfectionist, you might not really be a good candidate for some of these multifocal or extended depth of field lenses, which can cause other visual phenomenon. You might see, as we talked about, halo starbursts or things like that. Or maybe the contrast is not quite as good. All of this means that those lenses may not be good for you, even though they're accomplishing these things, and we can measure it and say, yes, you're reading 20/20, you're seeing 20/20 distance. But if you're a perfectionist, sometimes that you're not going to be happy with the lens, no matter how good our outcome is.
And all these things are starting points, right? This, what you mark here is not going to take a lens off the plate for you, but it is a starting point for this discussion you have with your doctor. And so just helps inform that and make sure that we're all on the same page. Okay, so let's pause for just a second and take a few questions. So Dr. Kedhar, will I be able to see as many colors as before surgery?
Mm-hmm. Yeah, actually, a lot of patients describe that the colors change for the better after surgery. And part of that is because as the cataract grows, it actually takes on a yellow or brownish color, which you can imagine sort of filters everything. Everything becomes more kind of sepia toned. When we replace that with a clear lens, now it allows a lot more of the blue light in. So a lot of times patients say, well, wow, the walls are whiter than I thought they were, or everything is like looking in through HD, right, or LED, where you're seeing things with a little bit more of a blue, not that everything's blue cast, but you're seeing things more in the true colors that they are.
And it's pretty shocking to people. Artists in particular, I love to see their reaction when they see more of the way things really are.
Yeah.
I've frankly gotten in trouble a few times with this. I've had people come in and say, gosh, I painted my house before I did my cataract surgery, and now I hate the color,
Or you have to change your whole wardrobe.
Right, things like this. Yeah. Or I see all the dirt on my floor that I never saw before. So let's see. I heard the laser method versus old-fashioned method gives more problems. You want to speak to that? Or I can speak to that.
Yeah,
so laser cataract surgery or manual cataract surgery, from an outcome standpoint, in terms of safety, is roughly the same. But what the laser cataract surgery does for you that the manual doesn't is help correct those smaller amounts of astigmatism that we talked about. So the real reason to do that is mainly astigmatism based.
Can looking at a computer or cell phone most of the day worsen symptoms? And do blue light blocking glasses really work? So when you're looking at a computer or a cell phone most of the day, what happens is that when you're staring at things or doing concentrated tasks, you're not blinking as often. Your blink rate goes down, which means that your eyes tend to dry out. So what can happen is over the course of the day, sometimes people notice that their vision is getting worse. They're getting more blurred vision, maybe more irritation, tearing, foreign body sensation. So it can worsen the blurring of the vision. Generally, people find that it worsens through the day and then they go to sleep. And when they wake up in the morning, it's kind of back to being, their best, and then gets worse over the day. So yes, it can worsen symptoms. But in terms of making a cataract worse, computer or cell phone use is not really going to do that. Cataracts kind of grow at their own pace, and not, for the most part, most of what we do on a daily basis is not going to make that worse. Do blue light blocking glasses really work? Yes, they can. One of the problems we have with blue blocking glasses is they're not necessarily standardized. So one of our colleagues, Dr. Mehta, actually pulled a lot of the blue blocking glasses and went and tested them in our lab. And a lot of them don't block blue light the way we think they should. And so blue blocking, we think blue light is having more of an effect, not only on keeping people awake, right, your circadian rhythms, but also it may contribute to macular degeneration, making it worse. We're not sure. So there's an argument on both sides there. Some people will argue that the blue light, you get a lot of blue light just from the sun. And so, you know, doing anything on the computer is not really going to make that much of a difference. But yeah, so blue blocking glasses can work. It's just hard because they're not standardized.
Okay, so we're going to push pause on the questions for just a few minutes and look at some of these lenses. Again, there are so many nuances to these lenses. Please consult with your surgeon about which one is right for you, but just so you can have a sense of what's out there. The far left is a monofocal lens. This one does not correct astigmatism, so it's going to help you see at one particular distance without the astigmatism correction. The second one, you can see these little dots here where my cursor is. Those indicate that there's an astigmatism correction built into this lens. This is a toric lens, also monofocal, meaning for one distance only, but this is going to help correct astigmatism at the same time. I'm going to take these two.
Sure. The last two, is it just
That's
monofocal?
LA,
Yeah. That's LA. Okay. So the third and fourth lenses are what we call more, or even the second one are what we call premium lenses, right? So these are lenses that are typically not covered by insurance. People pay extra money for them for this idea of getting better vision or more accurate results or a range of vision that they wouldn't get with the lens all the way on the left. So the third lens here from the left, this one with the blue legs on it, is a light adjustable lens. And this is a really fascinating technology that we have here. It was developed here in Orange County. And the lens basically is, we do all those calculations that you saw us do before to get a power for the lens. We can put it in the eye, but after the surgery, when the patient comes out, several weeks after surgery, we can start to adjust the power of the lens. So we've had some patients say, hey, look, I really want, so we brought up the concept of monovision before, right? So one idea is you could do monovision with these lenses. And then let's say the patient doesn't like it. Well, you say, okay, well, we can then change the power of the lens back into a distance prescription, for instance, or make both of them near vision. And, there's a limit. You can't, there's not an unlimited amount of change that you can make, but you can change it. And we can change it several times before kind of locking it into place. Besides the cost, I'd say the other downside to this is just that we have patients needing to wear, you need to wear these protective glasses because this lens changes its power with ultraviolet light. And when you're outside, if you're not wearing the special glasses, the lens may then change power without us wanting to do that. But you only have to wear the glasses for the period with which we're changing the lens. Once we lock it in and we say, this is where we want to be, we lock it in, then you can get rid of the glasses. The last lens on the right is also fairly new. This is called the Apthera IC8 lens. And what this does is, many of you have been to the eye doctor, when they take your vision and then they throw down something called a pinhole, they say, okay, well, let's look through these small holes. Is the vision better? And what that's doing is cutting down on some of the stray rays of light and helping your eye focus. And what they've done now is to incorporate that into a lens. And this lens will, for many patients, can overcome some of the more irregular astigmatism, meaning that, we saw earlier that topographic map where it looked like a bow tie. Sometimes it doesn't look like that. It's sort of scattered. And this can actually address that kind of astigmatism, whereas the lens here, the second one from the left, can only address it if all the astigmatism is in a line. But if the astigmatism is not in a line, the lens on the right can help. The other benefit of having this is that it gives people a depth of focus. So oftentimes people will get both good distance vision and reading vision with this lens all the way on the right, the IC8.
In terms of the light adjustable, are there any particular patients that you gravitate towards using that lens in?
Yeah, I mean, I think we any patient where we think that the lens is more likely to, or the calculations are more likely to be off. So again, with that graph that we talked about, if patients at the extremes of the axial length,
right.
But also more importantly, I think, and what probably you're alluding to is patients that have had refractive surgery, so LASIK or PRK in the past. Anybody that's had laser surgery on their eyes to correct their vision in the past, it changes the shape of the eye a bit. And when it changes that shape, all of the equations that we use are based on a model of the eye that's sort of perfect, one that hasn't had LASIK before. So when you throw in the shape of an eye that's had LASIK, it increases the error rate of those equations. Now, we've come up with a lot of workarounds to get closer to target, but even with that, the error rate is still higher in patients that have had LASIK than patients that have never had LASIK. So this gives us a little bit of an insurance.
Yeah,
right.
You can fine tune that, and it's really, I mean, it's really neat technology, but
Yeah.
there is a cost associated with it, and there is in terms of money, but also, like Dr. Kedhar said, in terms of time and coming back in and wearing those glasses all the time.
Mhm.
Okay, so we're going to go to a few more.
Yeah.
So I'll take these first two if you want to take the third one. So this these are all types of lenses that are going to give you more range. And the first one here, this is a lens that is designed to help you see basically two of the three. We're looking for distance and intermediate, typically is how we set it up, or for intermediate and near. And actually the second lens is similar. It's also for two of the three different ranges. You're going to have a little more glare and halos when you see when you see more rings like you do on the second lens. And so these are good lenses when maybe everything is not perfect. Maybe there is some, one or two aging changes in the retina, or some irregularity to the cornea, or some dryness. You want to get as much range as you can. This is a good way to get that without having some of the issues you would have if you try to go all the way and do a full multifocal, like you'll talk about the last one.
Yeah, and I think one thing I'll add with those is that with the first two, some people you might ask, well, why would anybody opt to go halfway, right? If you're going to pay for these lenses and have something, why not get something that I can see near, middle, and far? And part of the reason is because as we increase that range, there's more likelihood of halos, sometimes loss of contrast there. And these lenses on the left were designed to give people a range, but to lessen some of those other side effects. It doesn't eliminate it, but sometimes the satisfaction with the quality of the vision is better with these lenses on the left than it is with the lens on the right. Although many patients are very, very happy with multifocal lenses like the one on the right, which gives people near, middle, and far distance with reduced dependence on glasses for most situations.
Okay, so let's take a couple questions here. So can a lens be rejected by the body from an allergic or autoimmune response?
So yes, it can, but it's very, very rare. Most of these the materials that we use for lenses now have been worked through for a number of decades. And generally, these are very well tolerated by almost everyone. Very rarely, some people that have certain kinds of inflammatory conditions in their eye, they might be more likely to kind of attack the lens. And so we sometimes will not put a lens in, or we have to take it out. But I don't think this is something that the average person really needs to worry about.
And just as an aside, you couldn't have asked that to a better person. I mean, Dr. Kedhar, in addition to being a cataract specialist, a cornea specialist, is a specialist in autoimmune conditions of the eye. So he's the one to answer that question. Okay, can I get cataract removed, lens placed, insurance will cover, and continue to wear progressive glasses? Yes, you can get your cataract removed, the standard lens placed, no astigmatism correction. You can wear your glasses for, like we said in the other picture, for distance, intermediate, and near, and most insurances will cover all of that.
Yeah. I wanted to pick one question because I think that is something that comes up often, which is it beneficial to have surgery at a younger age, or should you wait? And I think the answer that, and this happens, I get this question a couple times a day, every day. And I think that what I usually talk to patients about is I say, the time to have cataract surgery is when you feel like it's affecting your vision and affecting your daily activities. So if that's younger, then, why suffer with vision that you're not happy with when we can do something about it? On the other hand, if you're happy with your vision, there's not really any reason to go get surgery just because you're younger and you're worried what might happen when you get older, because we just don't know what the future holds. Now, in terms of, there are some patients who are a little bit older and, well, I'll tell you, maybe this last 6 months, I've operated on a couple of patients who never had cataract surgery, and they were 93 and 94 years old, right? They finally decided to have surgery. So that's not typical, but they waited and they were healthy enough to do it. But some patients, as we get older and you get into your 90s, there's greater risk for anesthesia and things like that. And so it may make more sense to try to do it a little bit earlier. But by all means, by no means does it mean that you should be getting surgery in your 40s or your 50s just because, you know, someone says, well, you have a little bit of a cataract, but you feel like you're doing fine.
Yeah, there are a lot of nuances to that. I mean, we get LASIK to help us see without glasses, and that eventually doesn't really wear off. But again, the lens loses its flexibility over time. And so that someone who's had LASIK when they're young may lose the ability to see up close and may desire to have an improved vision both at distance and up close. And we're seeing people more and more often ask for that earlier in life. But in general, I agree with you that when it's bothering you is when that's the time to think about it. Okay.
And then there's one question about cost of lenses. I'm not going to necessarily address that because I think it's different depending on which place you go to. There's some places charge more for lenses and some places, but I'd say on average, a lot of the lenses are around 3,000 or so. Do you think that's about right?
3,000 to 4,000 for the lenses,
Yeah.
And then I mean,
for each eye,
the range can be up to $6,000 an eye, depending on exactly what kind of lens there is. So, and more expensive doesn't always mean better in your particular case, right? It depends on your goals, which is why we spent time, really prodding you or kind of nudging you to think about what your goals are.
And the other thing I always emphasize to patients is that, you're not, just because it costs more, it doesn't mean your vision is going to be better. What you're paying for really is this reduced dependence on glasses. So if you say, look, that's out of my budget to pay for this multifocal lens, don't feel bad, right? You're getting, every lens we have is amazing technology. Surgery now is remarkable. What we can do, in 10 minutes, that we weren't able to do several decades ago. So no matter what, generally, I'd say better than 95%, better than 98% of patients see better after cataract surgery. So you're going to see better. What you're paying for here really is this reduced dependence on glasses. And if you said, look, I don't care if I have to wear glasses, I'm fine with that. The regular old monofocal lens will be just fine.
There's one question that's come up a couple times, so I'll answer it, which is, can I safely get consultation and dilation twice in a week? And yeah, that's fine. If you're going to get your eyes dilated one place and you want a second opinion, that's totally fine to get it later that week. And okay, so a few more slides. This is a bell curve. Basically, this kind of just harkens back to this point that we put all the data into these formulas, and we try to tighten that bell curve as much as possible, meaning we try to get you as close to target as possible, but there is some variation in terms of how your eye accepts the lens and how it heals in place that we don't have full control over. There are some technologies, though, that we can use to help with that, and one of those is to take measurements during surgery. So you've had the cataract taken out, and then we take another 1 or 2 or 3 sets of measurements during the surgery to confirm that the plan we had is actually correct. And this is most helpful, I think, and also in those patients who've had laser surgery before, like PRK or LASIK. And then can't remember exactly what I was going to do with this part.
Was that a physics?
This is post-op refinement.
Yes, right.
Yeah. You want to talk about?
Sure. So the point of all this is not that cataract surgery is a crapshoot and like, well, just whatever you get is what you get, right? So all we mean to say is that when we do the surgery, we really try to nail the target, hit the bullseye. Sometimes we're off a little bit one way or another. And and sometimes we're off, but patients don't notice and their vision is fine. It doesn't make a difference. But if they do notice, or if they aren't happy with the vision, there are things we can do even after surgery to correct that. And one of those things here on the right is basically LASIK or PRKs, kind of laser eye surgery, where even though we've taken out the cataract and replaced the lens, there's maybe the patient's not happy, they're still a little bit nearsighted or a little bit farsighted. Well, we can do, and again, not for most people, we can then laser the surface of the eye, the cornea, to provide that added correction.
And another option that's not on here, but I think we discussed earlier is, can always remove that lens and put a new lens in. We don't want to do that. That's not a primary plan necessarily, but it is a safe option if need be. Okay, so we have a few slides here on dry eye. The dry eye question, dry eye is annoying, but has nothing to do with cataract surgery. Hopefully by now you know that's not true. It affects cataract measurements. It affects how crisp the vision is, and it affects light sensitivity and glare. And in the interest of time, I'll just say B, C, and D are all correct. A is not correct. Dry eye has, in fact, when you come in for a discussion about cataract surgery, it's amazing how much time we'll spend looking for dry eye, talking to you about dry eye, and thinking about the interface between dry eye and what lens we're going to choose.
Yeah, and I'll say, just from my experience, you might feel this way too, but I think dry eye is the #1 reason for people to be unhappy with cataract surgery.
Yeah, 100% agree.
Yeah.
And there's a few kind of drawings here that I'm going to walk you through. They're not the most amazing drawings, but this is what I try to draw for patients when they come in. I'll pull out a blank piece of paper and say, okay, this is your eye. The front part is the cornea. You have this lens inside the eye, and eventually that lens becomes a cataract when it becomes cloudy. But at the same time, you have these little dry spots on the cornea. And blurred vision, fluctuating vision, tired eyes, irritated eyes. These are complaints that people come with and say, look, I have cataracts. I have fluctuating vision. And already a little bell in my mind starts going off. Well, cataracts don't cause fluctuating vision. Cataracts don't cause tired eyes or irritated eyes. They do cause blurred vision. But all these symptoms can be symptoms of dry eye. So just speaks to the point of trying to treat both of these things, particularly treating the dryness before we do surgery and during and after surgery, because both the dry eye spots and the cataract itself can cause that light to be not focused. Again, this is a little graph I'll draw, just indicating that if your vision is changing throughout the day, that's not the cataract. The cataract is pretty stable over weeks and months, but if it's fluctuating from morning to evening, we're looking more at dryness. And dryness increases with time as you get older. Whether you have surgery or not, it's going to increase, and it will flare for a few months after surgery. So you can expect after surgery, I tell all my patients to use preservative-free artificial tears after surgery, just anticipating this flare.
So, Dr. Wade, what do you do if frequent dry eye drops are not helpful? What other options do patients have?
That's a great question. So we could give, there probably isn't a whole lecture on that. And we have handouts that kind of detail other things, but things like steroid or drops that are designed to help you make more of your own tears. There are anything up to punctal plugs and serum drops. What is your typical go-to if you have somebody who's kind of lined up for cataract surgery, things are a little too dry? What do you typically reach for?
I say in the immediate term, I oftentimes will use some steroid eye drops, because dry eye causes inflammation on the surface of the eye, and that inflammation then kind of shuts down the cells on the surface that produce the tears and help the eye lubricate itself. So kind of stopping that cycle by giving them a little bit of steroid for a few weeks can be very helpful. But sometimes we have to go with things like plugs, or even a drop called Restasis, or there's another one called Xiidra with an X. Both of these were developed as anti-inflammatory drops for dry eye that don't contain steroids, and so they can be used long-term. Yeah.
And this kind of piggybacks with the question that says, to treat dry eye, is tears or refresh PM the only solution? And no, there are a lot of different ways we can approach this and need to approach it sometimes. Let's see what else I got here. Okay, so we talked about different lens options, and we mentioned that if you're going to get a lens that's going to give you more range, and you have concurrent dryness, then you may end up with a great lens. If you have dryness, though, you may not be happy with the outcome that you've had. And this speaks to what you were saying earlier about this being the #1 reason for people to be unhappy after cataract surgery. And I've had multiple patients come to me from outside saying, I don't like this lens. We take our time, we treat the dryness, and all of a sudden things are better. They can tolerate that. Okay. Why don't you take this one?
Sure. How much anxiety is normal before surgery? A little or a lot? Probably varies on the patient, but I think whether patients let on or not, I think a lot of people have concerns. I mean, You are having surgery on your eyes. All of us are very, one of the number one concerns is of anybody, that we survey is losing their vision. And so, everyone's concerned about whether there could be problems from surgery or am I going to have other issues afterwards. So I'd say definitely there's a whole spectrum, but I'd say almost everybody has some.
And we just want to normalize that. I mean,
Yeah.
I was on a hike once and tore something in my hip and needed surgery. And I remember feeling anxious and scared and the whole works. So if you're feeling this way, that's normal. Please let us know how you're feeling. We can walk you through that and talk you through that. But this is, it does, and we really honor and respect and are grateful for the trust that you put in us when you give us a chance to help you with your vision. And we know that there's a lot of emotions that go through with that.
And I wanted to hit on one question that came up in the chat, because I think it goes towards some of these, some of the anxiety that patients have about complications. Most complications with cataract surgery occur in much less than 1%. So if you're talking about things like serious infections where we might have to give you injections of antibiotics or further surgery, that really occurs in maybe 0.1% or less of patients. Things like detached retinas or glaucoma, high pressure in the eyes, inflammation, all of these things occur, probably 1/10 to 0.2% of patients. So, most of the time I tell patients, you have a better than 99% chance of not having any complications, any serious complications with the surgery, like excluded dry eye and things like that. But, if you, for anybody that gambles or goes to Las Vegas, if I told you you had a 99% chance of winning and not having a problem, most people would take that.
Yeah. And if anything, were to happen, you want a surgeon or a group of surgeons going to walk you through that and kind of pull in the expertise needed to help treat that. So
do you know how long we have?
I think this is my last slide, actually.
Okay.
So, okay. Any other questions? Thank you so very much for spending time with us tonight. We know you have a lot of other things going on. Hopefully this was helpful.
Yeah,